Good morning and welcome to the Board of Directors for Lincolnshire Partnership NHS Foundation Trust. As is usual for the Trust, we start today's meeting with one of our patient stories, and the purpose of the patient story is to ground us in the experience of our patients and our staff within the organisation, and this will enhance the agenda of today's meeting. So today we have a story from our Adult Inpatient and Urgent Care Division, and I'm going to hand over to Cassie, who is going to tell us her story.
Good morning, everyone. My head is racing, sweaty palms, disordered thoughts, mental exhaustion. I call the police, desperate to escape my home, but my husband has locked the doors in an attempt to keep me safe from my plans to jump off a bridge. Big van, flashing lights, an altercation on the doorstep. Suddenly, I'm detained, rolling around in the back of the van. It stops. I'm jostled into a cell, mattress balanced on a plinth. It resembles a morgue. Kind voices penetrate the darkness of the situation, and cups of coffee break up the next monotony of 48 hours. Groups of professionals come in and out, bringing their own chairs. I'm sectioned. One of the kind voices opens the door and asks me to follow her out of the cell. I'm free, but I'm not. I'm taken to the ward, more kind voices, vaguely familiar faces, offers of tea and food. A doctor arrives. She is warm and friendly. She takes an interest in my story, no judgment. She takes my concerns seriously. I'm shown around the ward. It's all too familiar from 2 years ago. I find my bed space, head down, exhausted. I sleep after some night medication. I'm awake. The routine of the ward quickly establishes itself, punctuated by meals and medication timings. Cheerful OT staff and activities leaders break the monotony with offers of distractions, craft, art, games, baking, films, popcorn. Staff on the ward work hard, cycling through their various tasks, one-to-ones, observations, meds, ward rounds, bed changes, a steady stream of requests from the patients for cigarettes, vapes, leave, laundry, charging. All this alongside the general goings-on of a psychiatric ward. Alarms, lig knife, they shout. Restrain, calm, distract, diffuse, de-escalate. Some days are frantic, short-staffed and one-to-ones aplenty, leave no one on the ward to help the patients that need it. Lack of space in the staff room means they're fighting for computers to write notes. But somehow they manage, with compassion aplenty, kindness in droves, and a willingness to try their best for us all to get better.
Thank you, Cassie. I think there's a little bit of a delay in the tech today, so I think the camera will come off of you and go on to me any second now. But that was an incredibly powerful story, and you presented it like a professional. Honestly, that was to present that in this environment. Honestly, I applaud you. We're going to talk to some of the staff who have been with you today. So can I ask Jessica and the staff to introduce themselves, Cassie, because they're on screen.
Yeah. Hi there. So my name is Kashmir. I'm the ward manager on Charlesworth Ward.
Thank you.
Hi, I'm Jessica. I'm the occupational therapy assistant for Charlesworth Ward.
Thank you, that's great. Cassie, if it's all right with you, I'd like to open it up now to questions from our board members. If there's anything you don't feel you can answer, or if you want to defer it to to our staff who joined you from Charlesworth Ward, that's fine.
Okay.
So you're going to be asked some questions, and I'll ask them to introduce themselves first.
Yeah,
This is to get a sense of your experience and what we can do to improve our services, but also what was good about those services. And I was particularly keen on the word you used, our warm, friendly and non-judgmental staff. I'm really pleased to hear that. So I'm going to open up to questions, and the first question, Cassie, is from Chris Higgins.
Thanks, Sharon. Morning, Cassie. My name's Chris Higgins. I'm the Director of Operations here at the Trust. Nice to meet you, and thanks for sharing your story this morning. It was just a question really about how it felt coming into the ward. Obviously, you quite a traumatic experience in terms of all the things you talked about just then. But how did it feel coming onto the ward, and did you feel safe and supported? And what was the thing that made the biggest difference for you?
It felt really nerve-wracking to start with when you first walk on, and I have been here before, so it wasn't as bad as the very first time, but you get put in a room, and then the first thing that happened was someone gave me a cup of tea. I think that always helped. And then someone came and introduced themselves and said they'd be back in 10 minutes time to go through everything with me, so that reassured me.
Thank you.
Thank you, Chris. Cassie, the next question is from Anita Lewin.
Good morning, Cassie. I'm Anita Lewin. I'm the Director of Nursing and Quality here at Lincolnshire Partnership. I just want to pick your brain, and I'm not sure if it's you, if I'm going to kind of put Jess a little bit on the spot. But as part of what you were presenting, you spoke about some of the activities that are going on the ward.
Yeah.
And part of what you said to us was, you know, about the activities, the aid that you witnessed and had, you know, the opportunity. For me, it really is about the activities and kind of just asking about the importance they play in some of the recovery and distraction work that you talk about.
Yeah.
And it's not a trick question. It is just for you. You know, are there enough of you? You know, is there enough activities and the timetable available in the hours of the week? You know, do we need more Jesses, or do we feel it's working well? That's the bit for me. It's that whole activity and the importance of it.
I think there's enough at the minute, because you've got 2 occupational therapy assistants, and we've got 2 activity coordinators at the moment, because we gained the one from PQ. So that's working really well, because it means we sometimes even get a choice about whether to go to one or another. So that's working really well since we've had the extra one.
And that's something for us to think about. So what happens when we've heard, Cassie, your story, what we do is we have a conversation as well to say, is there more that we can learn? Is there stuff that we're not doing that maybe we could do better? And maybe we need to listen to that and kind of think, you know, with the extra occupational therapy assistant or activity coordinator, if that's making such a difference, maybe that's something we need to think about as a forward plan for the ward anyway. Yeah, you know, because the PQ will obviously reopen at some point, but actually if it's making that much of a difference, maybe that's something that we do genuinely need to think about.
Yeah, I think so, because activities are so important.
Yeah,
it's such a good thing to distract yourself from the monotony of the day and to get yourself moving forwards.
Brilliant, thank you.
Thank you, Anita. I'm going to bring in now Di Bailey.
Thanks, Sharon. Hello, Cassie. My name's Di Bailey. I'm one of the non-executive directors. Lovely to meet you. And actually, Anita has asked the question that I was going to ask you. So if I may, I'd like to ask you another question. And that is really about, I understand that you've been with us before, and obviously, so this was not the first time that you've come into LPFT. And I just wondered whether there was anything more we could do before you came into hospital in terms of planning with you for an admission, because it sounds like it was all a bit difficult, which often these things are, but sometimes if we can plan beforehand, it can help a bit. So I just wonder if you've got any thoughts about that.
Well, I was under the crisis team, and they did come and see. I was under daily visits.
Right.
They did come and see me that same day, but so they were trying to keep me at home with my husband, but things escalated when I got very distressed that he'd locked the doors because he was trying to keep me safe.
Right.
And when I called the police, so I don't think they could have done anything else. I think the crisis team were doing their best.
Okay, that's good to know then, and thank you for sharing your story. You were so articulate. It was really lovely to hear. Thank you.
Thank you, Di. I'm going to move on now to Sarah Connery.
Good morning. Hi, I'm Sarah Connery. I'm Chief Executive here at the Trust. So thank you so much for joining us today, Cassie, and the Charlesworth team. And I don't know what's going on because Anita stole my question and then Di stole my supplementary question. So there's lots of great minds thinking today. But I found your description of sort of that night is almost poetic. It was so insightful, and you can almost feel how it would be in that situation. So thank you so much for being brave and sharing today. It's really helpful for us to hear. So I'm going to take a different tack and ask Cash and the team, what in terms of the new build, what are you really excited about? Because it's on the horizon now. We can almost sort of can get excited about an actual move in. So just welcome people's thoughts really in terms of the care that Cassie's had on the ward versus what it might look like in the new build. If that's okay. Thank you.
Yeah, of course. I think it'll make such a big difference to the environment and to the feel of the ward. As Cassie's described, it can feel quite chaotic sometimes. We have limited space, and actually in the new build we have so much more space. And it'll be a case of, we'll be moving from dormitories into, people having their own bedrooms. I don't know how you would feel that would make a difference.
Yeah, I think there's pros and cons of being in a bay, because sometimes you can actually, create positive friendships, but I think it will be much better having your own rooms, because then you've got your own space, and then you can still create those positive friendships in the communal areas.
Mm-hmm. And we'll have more space, for nurses in the nursing office, and more space as kind of on the ward to engage in those activities, because at times, we're a bit limited to what we can physically do on the ward and to what has to be kind of done off ward in the hub area. So there'll be more opportunities to have even more activities take place on the ward.
Well, thank you so much. Thank you.
Cassie, but the final question is from Girish, who's our medical director.
Hi, Kathy. Good morning. Obviously, as a clinician, I do see patients face to face. However, someone like you coming to this forum and talking is very, very different, and it is very powerful. Thank you for that. My question was related to your family and your carer. How was their experience before you came to the ward, and also your stay on the ward? Thank you.
Well, my husband actually is a GP and has a lot of a background in mental health. He has a special interest in mental health, so it's a bit like a busman's holiday for him, me going downhill. And so I think he tries so hard to keep me at home, but in the end he couldn't. And the support he got when I joined the ward was great because of Di, the carers champion. He's been up to date with everything, and she phones him and gets updates him. And I think this particularly compared to when I was on Ward 12, he feels a lot more involved in the decision making, and they always make sure they phone him. Dr. Ishmael always phones him on the ward round and makes sure he's involved in the decisions. So it's been good experience.
Thank you so much. Thank you for that.
Thank you, Girish. Cassie, that is the last of our questions from the members. I just wanted to ask you before you go, if there was one thing you'd like to be different, what would that be?
That's a tricky one. Just for it to always be well staffed, I think.
Yeah, yes, I agree. Very important. And a big challenge for us as an organisation, and a big challenge nationally.
Yeah.
So thank you for being with us today, and thanks to our staff as well. Thanks, Jessie. And you've disappeared. I can't see you on the screen, but I know you're there somewhere. So thank you all for being here. We're going to move on now to the routine business. So we'll say goodbye to you. And thank you, Cassie. That was really, really well presented, and it's going to be so useful to us throughout the day. Thank you. Bye.
Thanks, everyone.
Thank you. Thank you. Bye.
Okay. So moving on now to the routine agenda of the board, just to point out that our chair, Kevin Lockyer, will be joining us as soon as he can. There are a few IT problems that we've all been experiencing this morning. So my name is Sharon Robson, and I'm the Deputy Chair for the Trust. I'm going to move on now to declarations of interest, and declarations of interest have been set out in paper 1.2. Are there any other declarations of interest that anybody wants to raise on today's agenda? Right, okay, I haven't got any, but I do have apologies from Tim, one of our non-executives, to mention. Thank you. So moving on then to the minutes of the last meeting of the board, which took place on the 1st of December. For accuracy, do we have any points of accuracy on those minutes? Okay, I don't see anybody coming forward with points of accuracy. So we're going to accept those as an accurate record of that meeting. And if you could just indicate in the chat bar that you accept that that's an accurate record, that would be great. Thank you. Thank you. Schedule of actions 1.4 on the agenda. Are there any actions that anybody wants to pick up on today? No, so those oh, Sarah, just in time.
Sorry, I had a chat bar misfunction, so apologies. It was just a small thing, but I think the two actions around Mental Health Act monitoring need merging into one, because I think ultimately they're sort of asking the same question about monitoring of information for Mental Health Act based on protected characteristics. So if we could just have those merged, that would be helpful. Thank you.
Okay, thank you, Sarah. So next on the agenda, we have Chair's remarks, but as our Chair isn't able to remark at the moment, I'm going to move straight on, Sarah, to your report, Chief Executive Report.
Thank you very much, Sharon. Thank you. So morning, everybody. I'm Sarah Connery, Chief Executive here at the Trust. It's quite a substantial report this morning. I make no apologies for that. I think it's a reflection of the many sort of pieces of transformation that are happening within the Trust as much as in the system and at region and indeed at national level. So to start off with, I haven't included about industrial action. none of the trusts in the county were actually above the quota required in terms of industrial action, but EMAS, East Midlands Ambulance Services, did. So we were impacted from a patient flow point of view. And I just want to say that as we do in Lincolnshire, the system pulled together really well to make sure that there was as little impact on patient care as possible. And we continue to work really closely together for any future instances of industrial action as well. So I just wanted to make that point. In terms of infection control, we have moved back to universal mask wearing. It was a decision that we took over the festive period. We continue to be on sort of a higher level of infection prevention and control until the 31st of January, at which point we will review again. And that was in relation to rising infection rates, not just for COVID, but also for other respiratory illnesses, influenza, for example. And we're tracking our staff sickness around that very closely on a daily basis. From a national point of view, I just wanted to take a minute of your time to point out the patient and carer race equality framework, which is coming on. The draft was actually launched week commencing 12th of December, but we've got greater clarity now in terms of the requirements for us as a trust, which will be mandatory. So there'll be a further detailed paper in terms of what that means for us in terms of our approach to reducing health inequalities by the end of this financial year. And Dr. Girish Kunagiri will be our executive lead for that. I've included a section around operational planning guidance, and I know we've got a more detailed discussion around what that means for us in terms of part 2, but the key point for us is to make sure that we get ourselves as a system out of the recovery support programme. We still are operating framework level 4, and we have an ambition to make sure that we're in 3 and then on to a 2 going forward. So there's a lot of work that's going on. Operational planning is complicated enough, but it becomes really complex when you consider that we have to make sure we're aligned with all of our system partners as well. But the key points for us from an LPFT point of view will be triangulation of workforce activity and finance and performance, and also deliverability to make sure it's a plan that we can all get behind. In terms of other national programmes of work underway, I also just wanted to point out around the Hewitt review, which is an independent review of integrated care systems. As we all know, ICSs came into force under the Health and Care Act on the 1st of July, but this is about a bit of a stock take really in terms of where we are and how do we maximise the impacts that our new structures make in terms of delivering better patient care, better patient outcomes and access. So terms of reference were published on the 6th of December, and the section there talks about some of the focus of that piece of work. Again, it's something that we can pick up in our part 2 for a more in-depth conversation. Moving more back into sort of Lincolnshire, I've included some pieces there around Young Minds Matter, which is the contract that we'll be handing over from the 1st of April. It's now officially announced that Navigo is going to take on that contract. So myself and the Chief Executive of Navigo met with all of the Young Minds Matter staff early in March to launch the formal consultation and just have a bit of a question and answer session in terms of any fears, but also to talk about the great opportunities that transfer allows for the children and young people of North East Lincolnshire. I've also included, in terms of the latest Better Lives Lincolnshire executive team, we had a really positive presentation from City and Borough Councils about the Towns Fund bids, the successful Towns Fund bids, which is a fantastic piece of investment into Lincolnshire, again with a lens on reducing health inequalities and improving the well-being of our population. We've also had the Director of Public Health's annual report, and I've included a YouTube video just to make it easy for people to be able to access the key points of that. But the key reflection for me is we're really starting to get a better grip as a system around the differing needs of our differing areas, primary care networks, however we want to cut it, we're really starting to connect up that bit of information. The key point is, how do we actually address any inequalities and specific needs in terms of resource allocation and care pathway models. Also delighted, and a massive thank you to Community Transformation Programme and system partners in terms of the launch of the How Are You Lincolnshire website. Again, the link is there in the paper, and I really do urge people to have a click and have a play, particularly if you do live in Lincolnshire. And the point is, if you know who owns your bin, you'll know which area to click on in terms of all the groups and activities and support that's available for people out in their communities. I do have to say, this is the last formal board that Anita Lewin is here as our Director of Nursing, AHPs and Quality. So we've tried to keep her as long as we possibly could, but she's finally decided that she's going to retire after a very long, successful career with LPFT. So I just want to say personally a massive thank you to Anita for her support and her patience with me as a non-clinician. In terms of some of my questions, in terms of, well, how does this work and what does this mean? She's very patient with me. So we've got already underway with the planning of the leaving do, which should obviously be very important to Anita. And as you'll see from the paper, we've got Anita's replacement, Sharon, starting mid-February, who's looking forward to starting as our Director of Nursing and Quality, before fully taking up the role in April, when Anita does finally retire. I'm on the long straight now, apologies, I'm running out of steam a little bit. Just want to say a massive thank you to the Maple Lodge staff who had a Mental Health Act inspection, a CQC Mental Health Act inspection, and there were no actions to address at all in the report, which is really no mean feat. So that's just testament to the quality of care that's delivered over in our Maple Lodge rehab unit. Included there is quite a substantial list of the consultation and engagement. So a big thank you to all of our staff and our population who are getting involved in some of that. It's really important that we hear people's views on some of the changes that we're proposing, and also making sure that their voices are heard in terms of the models that we'll deliver going forward. So please do get involved there. I'll finish finally with allied health professionals. So in terms of celebrating success within the Midlands, there's Health Education in England's celebrating inspirational AHP work, and you can see from there how many nominations that we got. So many congratulations to all our nominees, in terms of special congratulations also to Gabriella Armstrong, who was the overall national winner in Positive, Compassionate, Inclusive Care Award. So that's no mean feat. I just want to finish by saying, even though we've had an unprecedented period of operational challenge, we do keep saying that quite a lot in terms of unprecedented, but with cumulative impacts of staff sickness and industrial action, and rising infection rates. But there are some real positive green shoots, I think, not only for LPFT in terms of our new wards opening this year, but also in terms of Lincolnshire investment as well. That'll make a real difference to our population. So just want to say a massive thank you for staff for pulling together and keeping service going during really difficult times. So I'll stop there. Sharon, thank you very much.
Okay, thank you, Sarah. That was a really comprehensive report with a lot of information in it. I just, while I've still got chair's prerogative, because I know Kevin's joined us, so I'll probably be handing over soon. I just wanted to note the incredible amount of work that's going on under challenging circumstances, and that's down to some great leadership by the executive team. So I just wanted that on record, and to reiterate the thanks to staff, particularly Maple Ward, which I visited quite recently. So I'm going to open this agenda item up to any questions by others. I haven't got anything for you just yet. Yes, questions are coming in now. So Chris Wright.
Thank you, Sharon. Chris Wright, Non-executive director. Sarah, thank you. And I'd like to echo Sharon's observations about the breadth of activity and the quality of the work that goes on, and your emphasis on lots of the positives that are taking place in a world where we spend a lot of time worrying about the challenges. It's good to talk about some of the positive things as well. My question was about the Hewitt review, and I read Patricia Hewitt's letter setting out the breadth of the inquiry and the time frame, and the time frame's quite short, isn't it? I think she's going to be reporting in March, and it really is one, you know, my concern is whether actually you can do justice to the extent of the inquiry within that time frame, but secondly, how we are contributing to that and ensuring that the voice of LPFT, but also the people we serve, is heard and hopefully listened to.
Thank you. Yeah, absolutely agree. I think in terms of the key priorities for that review, I think to be able to one of those justice in the period of time will be quite a challenge. I think that the actual letter, and I know we're going to talk about it later, was addressed to ICB and ICB chairs and chief executives. So my intention is going to be to get in touch to say, well, how our provider CEOs, chairs, non-executives and executives going to be involved in that, because it isn't clear from that letter. So that was going to be my takeaway. But I absolutely agree with you, Chris.
Thanks. Look, I think we've got a lot to say, and I know it's very early days on the ICS, but we must ensure we contribute. Yeah, absolutely. Yeah. Thank you.
Okay, thank you. I don't see any other questions for you, Sarah. So we're going to move on now to the next report, which, oh, Ian, did you have another question? Did you have a question? Sorry.
Yeah, I do. Yeah, apologies. Yeah, I forgot to press the button. Sorry. Ian Orrell, one of the non-exec directors. Just to echo what was said previously, Sarah, a really helpful report. I found it really useful. And a little bit of a similar theme, really. I just wanted to pick up the item on operational guidance, which is clearly something that you know, takes a lot of energy, I guess, within the organisation and is important. I just wondered, though, within all of that, are there any particular concerns for us as a trust, given that, you know, this is sort of, I suppose, looking over an 18-month horizon, and it's very much written as a, you know, at the planning stage as opposed to delivery, and it just struck me as, you know, is there anything that we should be fearful of?
Yeah, really good question. So I think first and foremost, it's delivering the access targets required in the long-term plan, and whether we're able to recruit sufficient workforce to be able to deliver that. And you'll see from the integrated performance report around those access targets that we're not currently able to meet. I think it's upon us now to make sure that we are triangulating our finance, our workforce activity and our performance data appropriately. So, for example, does it take 2 extra staff for us to hit that access target, or is it 10? And if it's 10, when will we hit 10? And I think we just need to get a little bit more robustness in our plan around that. So the deliverability element is known by us all at board level, and then the associated risks to delivery on that are a lot clearer. I think the mental health investment standard, in terms of potential underspend against that this year, and how between us and our commissioners we can build a really robust plan to make sure that we're making the difference that investment demands of us, really, in terms of making sure that we've got parity for STEAM with physical health. So I just come back to our risk register, really, which is workforce, but then us understanding the associated risk and impacts of that. That's my view. I don't know whether other execs might want to come in with their thoughts.
I think all is quiet there, Sarah. So, oh, Chris, are you coming in there?
So yes, I'm just struggling with my technology. So yeah, Chris Higgins, Director of Operations. It was just to kind of reiterate what Sarah said there. I think, you know, as we go into this next year, what we do know is we were quite optimistic, I think, about in terms of workforce projections that would lead to the capacity to meet those access targets. And I think there's two things at play there for us. One is demand on services. Some services seeing people increase demand, people waiting to get in. We need to obviously address that as a priority. But then there's also people are not waiting. The recommendations and targets that are set within the long-term plan for access are reflective of there's a population need out there that's currently not being met. And so it's beyond just meeting the current demand. It's been able to have the capacity and capability to be able to support people who might not be seeking care and support, and making sure they get appropriate treatment when they need it. And so so there's much work to do, but it's not a case of we won't be able to do it at all. It's about when, I suppose, and that's that effective planning to say, what's our rate of recruitment, what can we do in terms of maximising the productivity and efficiency of what we've got in terms of our current workforce, and seeing more people and opening up that access. So that's where I think we're in a much better position this year than we've been previously. The learning that we've had this year, particularly operating in this post-COVID world and the workforce pressures that we've had, we've got a year under his belt to be able to take into this next year of planning, but it is complicated, and there is a bit of a crystal ball in terms of workforce supply and what the demands are going to be in this coming year. So, so there are some challenges within that, but we're in a better position than we were 12 months ago, I'd say.
Thank you.
Okay, thank you, Chris and Sarah, for that. So we will move on now then to the next agenda item, which is our 2.2, is the organisational risk register, and we're with Jenna Davis for that item, and I'll be handing back then to Kevin Lockyer, the chair.
Thanks, Sharon. Good morning, everybody. I'm Jenna Davis, the Director of Corporate Governance. I'm going to take the item as read, and just to note that our board assurance framework, which normally is reported with our corporate risk register, owing to the changes of cycle in terms of the board, we've moved to bi-monthly committee meetings. It does mean that our BAF hasn't been through all the committees, and therefore it isn't on the agenda for today. So just to highlight that. And as I say, take the report as read if anyone's got any questions.
We've got a question from Di, Jenna.
Thanks, Sharon, and thanks, Jenna. And it may just be the way that the paper is the way that I'm reading the paper. But when I looked at the two risks that have been de-escalated to the divisional or corporate register, and then I looked at some of the other papers that we're due to consider in this meeting, where we allude to with, you know, an increase still in use of agency, and in terms of the integrated performance report, some of our data around wait time still. I was I couldn't quite square it in terms of why we're de-escalating these risks. I think it's probably because what we're saying is that that it's the operational areas where we will put in place the mitigations and tackle it. But I guess I just wanted to check that out in terms of, am I understanding this right?
I think Jenna, Chris is able to answer that one.
Yeah, thank you. Yeah, so Chris Higgins, Director of Operations. Yeah, it's just picking out the two risks, because I'm exec lead for both of those. It's just the reason the risk score has been reduced is to reflect the progress that has been made, and progress has been made on both of those. So in terms of risk 18, which is the inpatient staffing issues, is that because of the decision we made at the end of the last calendar year to temporarily close the PQ, that has relieved the pressure a bit on services, and so we've got one less ward to be able to staff, and the staff that they've been released, which was obviously the purpose of making that temporary closure. And we've secured a number of agency staff on a block book basis, so that obviously from a mental health perspective on that continuity care, and those things combined have reduced the number of staff we're looking for bank shifts and temporary staffing on a day-to-day basis. And because of that, we've reflected that in the likelihood of the impact is slightly less, and it's just dropped the score. But just for context, it's still a high risk, it's just not as extreme as it was previously scored. So we feel that we're confident that we've got the things in place to manage that, but it still remains a high risk. Similarly, the risk 209, around demand and capacity, the risk linked to not having the right investment and the right workforce. But what we've seen over the last year is that we've secured the investment into CAM services, autism services, and the places where we've been struggling the most to meet demand. And we're seeing a positive improvement that's starting to be reflected in waiting times. Now, people are still waiting. It's still not where we want it to be, but there has been a positive progress. So again, we've reduced the likelihood score. That means it's still a high risk, but not extreme that it was previously.
Okay, that's great. Thanks for that. It's really helpful.
Thank you, Chris. We now have Kevin.
Thanks, Sharon. Kevin Knockley, Trust Chair. First of all, apologies for being unconscionably late joining this meeting, but I had a complete tech meltdown. First of all, I couldn't unmute myself on Teams, and I took the strategically foolish step of rebooting every machine I had, and none of them took less than half an hour to get ready. So I'm really sorry about that. And Sharon, thank you very much for stepping into the breach at like 90 seconds notice. So thank you. My comment is exactly on that risk, Jenna. I think we've got this fundamentally wrong, both in terms of process and outcome as far as that risk is concerned. Two things. The first is that this is the corporate risk register that's owned by the board, and we shouldn't have risks being taken off of it without the board agreeing. So I think just reporting a decision to remove a risk from the register isn't acceptable. That's not how we should do it. It should be a recommendation to the board to remove that risk from the risk register. And if you had recommended removing workforce from the corporate risk register, I'm not sure that I would have agreed. It just seems to me to be fundamentally wrong, given the pressures that we know that we've got around workforce, for that not to be a key corporate risk. And I'm not comfortable with it being monitored elsewhere. We've said as a board, publicly and internally, that workforce remains our biggest risk. If I then go to the risk register and it's not there, then that just doesn't feel right. So 2 points there. The point about process, don't think we should be taking risks off the register without the board agreeing. So I think they should be recommendations to the board. And I think we need to look again at whether or not workforce risks should be somewhere other than on the corporate risk register.
Agree with both your points, Kevin. So we'll make the changes to the process, and obviously we're currently looking at the policy and that process at the minute, so we can make sure that that's clear within the policy as well. On your second point, I think the missing link at this meeting at least is the BAF, because obviously we have got the workforce and the overall trust risks around workforce contained within the BAF. Which then obviously links in with the corporate risk register, but take on board, and I'm happy for those to be re-escalated onto the corporate risk register moving forward.
Yeah, I hear what you say about the BAF, but I don't think that we can properly reflect what we think is the risk around workforce and it not be on the corporate risk register. That just doesn't feel right. And that isn't to say, and to Chris Higgins' point of a moment ago, that isn't to say that we're not that the risk might have changed. And I'm not suggesting that we don't make adjustments to the overall risk score to reflect change in circumstances. But I don't want workforce dropping off the corporate risk register. That just doesn't feel like the right approach.
So we'll get it re-escalated, and we will make that that update and review that the the risk scoring and the mitigations for the next board meeting.
Great stuff. Thanks, Jenna. Thank you, Chris. Seeing your comment in chat, I appreciate that. Hope you understand where I'm coming from on that. As I say, it's not to downplay the progress that we're making, but I think as a board we need to stay very, very focused on workforce issues, and anything that gives the impression that we're not, I am instinctively uncomfortable with. Okay, shall we move on? Thanks again, Sharon, for doing that. The feedback from colleagues in chat is that you've done a consummate job, and so perhaps it would have been better if my machine had taken longer to reboot. So let's move on then to, I think we're on item 3.1. You'll have skipped any remarks that I may have made under 1.5, but I'll come on and I'll come back to kind of chair's general comments towards the end of the agenda when we draw things to a conclusion, rather than take us back up the agenda now. So I think we're on item 3.1, which is a report from Quality Committee. Di.
Thanks, Kevin. Hopefully the report is pretty self-explanatory. I think it reflects the work that we've been doing with Quality Committee over the last couple of meetings to shift it to a more focused agenda around some of our strategic issues. So I wasn't really planning to add anything other than what's there, but happy to take comments and questions from colleagues.
Thanks, Di. It does, as you say, speak for itself. Has anybody got any comments or questions? I don't see any. Thank you very much, Di. So we'll move on then to item 3.2, which is the Guardian of Safe Working report. Girish.
Yeah, thank you, Chair. I'm Dr. Girish Kunigiri. I'm the medical director for LPFT. I guess you all had the chance to have a look at the report, but I want to just highlight some of the key points with regard to this paper. Just to give a context, that LPFT is a teaching organization, and we have junior doctors who are both in the training posts as well as the non-training posts, such as the international recruits and some of the local posts what we have. In total, we have about 40 doctors at any given point of time, and they rotate either within our ICS or sometimes within the North region as a part of their training, which is once every 4 to 6 months, depending on the nature of the training post they are having. Generally, the trainees have a positive experience, which we get through the annual deanery survey, and the doctors do have different channels of raising if they have any issues, like having weekly one-to-one supervision with their consultant colleagues, and also having regular meetings with the tutors and director of medical education. They have monthly junior doctors forum, and also in the last couple of months we have recently started medical directorate surgery, where people can chip in to talk about their experiences. So we have different forums, and the doctors do have on-call rotas with good rest hours and rest facilities within the organization. And this escalation report is one of the other means where doctors, generally, if they didn't have proper European working directives, they are able to raise. Similarly, if they have any concerns related to their training or service delivery issues, they do raise. As you can see on the report, that there were 2 isolated incidents with regard to exception report, and both were related to the on-call issues, which sometimes does happen, now and then, particularly when doctors go off sick with very minimal notice. We request the existing on-call doctor to continue until we are able to arrange, which may take a couple of hours. Just for information, the key issues what we are having within the organization is related to wide geographical area in Lincolnshire. So as a result of that, the doctors find difficulty in terms of going to different parts of the community mental health teams, particularly those who are in the periphery. And the second thing is, when doctors are posted into these communities, they felt isolated and was difficult for them to come for the teaching programs, which usually happens in Lincoln. So to manage this, where the director of medical education, based on the feedback from the doctors, have pooled them mainly near Lincoln, Boston, and Grantham, so that they get good support and also able to meet with their colleagues. And also with regard to the teaching and training, we have used a lot of online technology along with monthly face-to-face meetings. So in general, I want to just assure the board through this paper that we are looking after our doctors well, and we have less number of exceptional reports as an organization. Thank you. Happy to take any questions.
Thank you, Girish. I think we've got a comment from Sharon.
Yeah, thank you, Girish. In a way, you've kind of answered this for me, but I'm really surprised, given our workforce pressures, that we only had 2 exception reports in the period, and it probably is reflective of the good work in place. But when you're out and about and meeting staff and you hear of the pressures and medical and nursing staff and the fact that they have to cover quite a lot of different shifts for one reason or another. So how are we assuring ourselves that actual process is accurate and we haven't got more than we're actually recording?
Yeah, no, that's a very good question. I think for us, the key thing is engagement, because most of the staff do know where we are in terms of our staffing arrangements. And that is why the system, what we have put in place, is like a holistic approach from all the doctors group rather than just one subgroup. Like, for example, if trainees are unable to step in, then we have a process of step down approach where the specialist registrars will step down. Similarly, the consultants will step down so that we cross cover each other. And then again, within the inpatient setting, we make sure that whatever is needed in terms of the training, we have protected time. And at that point of time, we use our SAS doctors to cross cover each other. So in that way, with the existing resource, we are trying to manage as best as possible. And international recruits has definitely made a positive impact as well. And we are hoping that the 5 more who will be joining in April will ease some of this situation for us. Thank you.
Thank you, Girish. So just to follow on comment, that is, clearly there's something that's working really well here, and I wondered whether you had the opportunity to share that with our nursing and allied health professions to see if there's any similar thing you can do to support those professionals.
I'm happy to do that. Our on-call rota for doctors works a bit different to the nursing team, but I'm happy to have conversations with Anita and Chris on this and then see how we can use some of this. Yeah, and just to add to your question, we also have the software which is called Allocate, which is also really good in terms of identifying the gap much earlier, and also doctors knowing where the gaps are and if they are available during that time to come forward and fill those gaps. Yeah, that has also assisted in terms of managing. So yeah, we can definitely use some of that to help with the nursing as well. Thank you.
Thanks, Sharon. Sarah.
Thank you, Chair. Thank you, Girish, for the paper, and it's great to hear that there's no concerns highlighted in the feedback. But I think it'd be really good if we could have a bit more on that in terms of is there a trend? It's quite subjective to say there are no issues. Now, have we got any sort of quantitative data? And how do we benchmark, for example, across other partners with East Midlands, for example? But and just an offer, I'd love to come along to the Junior Doctor Forum and just say hi and talk to them. So if you want to get me invited along, I'd be happy to attend. Thank you.
Yeah, thank you so much. Just to quickly respond, the deanery does provide yearly report, which has some qualitative data as well, which I'm happy to share here, in our next round. And yeah, we very much welcome you to join for the Junior Doctors Forum as well. Yeah, thank you. And just to add, 90% of our trainees, particularly the specialist trainees, they join LPFT, which is a good sign as an organization, although we have only 5 senior trainees at any given point of time. But it's a good sign that we have been able to retain so many doctors, although they rotate in the whole of the North Midlands area. Thank you.
Brill, thank you very much.
Thanks, Sarah. Thank you, Girish. I've got one question, and it's about presentation of information. I think as much as substance on the on page 2 of the report, Girish. There's information on the use of locums covering shifts, and it says how many shifts have been covered in each month, but I don't know what that is as a proportion of the total number of shifts. And I think it would just be helpful to say that, to set that out. So I don't, 20 is obviously more than 7, but I don't know what that looks like in terms of the number of potential shifts in that period.
Yeah, thank you. I think every day we have 2 shifts, morning and evening, or night. So yeah, I can put that next time.
So 20 is half, essentially almost half the shifts in a month.
I mean, this is for 3 months report.
Mm-hmm.
So if we have 60 per month, so it will be 180 total shifts in 3 months.
Yes. Okay. All right. That's helpful. Thank you.
Thank you.
Amy.
Hi, I'm Amy Beaton, Director of People. It's just a comment on some of the page 2 in the paper. So it talks about MTIs, which is a medical training initiative, and I just wanted to highlight in the wording really of the paper, these are international doctors, so you'll see it said they couldn't be added to the rota until a few months after starting, and I just wanted to clarify there is normally an 8-week shadowing period before we do add them to our rotas, due to ensuring that they're well supported and got that confidence before starting. We extended it in this situation due to personal circumstances, but it was to enable them to make sure that they've got all the support they need before they're added to the rota.
Thanks, Amy. Thank you very much, Girish. It's been really helpful. If we move on then to item 3.3, which is the suicide prevention strategy update. Anita.
Yes, thank you. Anita Lewin, Director of Nursing, Allied Health Professionals and Quality. This is here just for information. This was presented to Quality Committee in detail by the Deputy Director of Nursing, who leads the suicide prevention work on behalf of the organisation. But that there is a kind of a need for it also to come to Trust Board. Just to give some national context before I move through to some of the bits on here, that there is a new national strategy. We are due an update of a new national strategy, which was due November, December. There has been a national conference on Tuesday of this week where they have kind of declared they're hoping to get that to us in the spring. It hasn't arrived yet, which from an LPFT point of view will fit very well with the work that we're doing currently around the trust strategy and how this piece of work fits into that. I do have to say, I think our suicide strategy, probably more than some others fits very closely with the system work around suicide prevention. We know as a system, unfortunately, a lot of people who do go on to successfully kind of perform suicide aren't known to LPFT services, but actually that doesn't mean we shouldn't be involved in some of the system work. And I think the last 12 months we've really stepped up a level in becoming involved with the suicide worker, and that's from Sarah Connery as our CEO, from Fiona Bone, our suicide and self-harm lead in the organisation. And I know a lot of the community transformation work is linked very closely with the suicide prevention work. So as a system, we're very much at the table on that. We're not just doing this small amount that touches the mental health services. And I believe when we update this strategy in line with the trust strategy, that will feature very much a part of that. In terms of LPFT and the key focus on us, we know nationally that there are a high number of deaths that are linked to patients that are on leave from inpatient mental health services. So some of our local markers and some of our local indicators have been very much around that piece of work. So each of the operational divisions have their own kind of dedicated work streams that they are progressing at pace. I have to say that they're doing some very good work within the operational services. At Quality Committee, and we had a long discussion about the papers that feed out from the strategies, and very much the so what difference is our work making. And Quality Committee is going to be receiving kind of reports on that really identify the so what part for the patients that touch with LPFT. So in summary, we are waiting for the national strategy. I do have to say there was a real focus at the conference this week of they're anticipating a potential rise in suicide, given some of the key kind of economic, financial and the general kind of way the country is feeling at the moment, that they are concerned that we potentially will see an increase in suicide, but that doesn't mean that we shouldn't continue to progress the fantastic work that we are doing. Lucy Gavins in public health has really got hold of this agenda from a public health point of view, and we're really closely linked with her. So for us in LPFT, we are doing a full review. We are going to wait for the national strategy to make sure ours is aligned, which will fit perfectly with the timings of our new trust strategy. Quality Committee have kind of given a very clear steer to our internal Patient Safety and Experience Committee on the so what information it wants to receive going forward. And that work was discussed in detail at Quality Committee. So I'm happy to take questions, and it is here. Just as a summary, really, to be fair, of the work that's been done and the next steps.
Thanks, Anita. I've got two comments or questions. I'm not sure which they are, if you don't mind. The first is, what's the governance around the Lincolnshire system-wide strategy? Where does that report to, and who tracks progress on it, is the first question. And the second is, how do we measure? I absolutely recognise the work that we're doing as a trust, which is great, and you know, absolutely support and endorse that. Where do we measure the impact, or how do we measure the impact? I mean, that methodologically tricky, I imagine, but how do we do that?
So Sarah, do you want to pick up the system one? Yeah. You popped up in front of me as if by magic.
Hi, yeah, no, so public health are very much in the driving seat around the system suicide strategy, and as Anita said, we're very much bolted into that. So for example, it was myself, public health, and Fiona, our suicide strategy lead, who presented at various council meetings, for example, in terms of that. But in terms of the governance, it reports into the Mental Health, Learning Disability and Autism Alliance, and then onto the Health and Wellbeing Board. So it's within that governance line.
I thought it probably was, but helpful to have that confirmed. Thanks, Sarah.
And picking up on the second part of that's a piece of work that because we do know in terms of suicide, often we have to wait for coroner's outcomes to get kind of that level of detail. However, and Girish is also on the call. Myself and Girish are doing a detailed piece of work with Lucy Kent, who is joining this meeting in a little while, around the reports into mortality surveillance and how that works and how that fits, and then the ongoing reports into PSEC in terms of our internal governance and the impact. So that is the work we do. And we do know for us as an organisation, there is kind of very clear monitoring that is in place around kind of suspected suicides and suicides when people are on leave from an inpatient unit. And that's almost easy to monitor. They're the ones that are easy to monitor. It's the ones that have touched part of our services and then don't have contact with us for a while. I have to be honest and say it's all work in progress in terms of the data. You made the comment it's a data nightmare, and it absolutely is, but it shouldn't be about data. But it's important that we have that. So we are currently kind of out to 10, or we're trialling some new data systems which will help some of that. But certainly the work that Girish and myself are doing to align Patient Safety Committee, learning from deaths and the mortality surveillance will help bring all of that together into one reporting line, which will go through to Quality Committee.
Thanks, Anita. That's really helpful. And you are, of course, quite right that we can't always neatly reduce, complex personal issues down to data. But on the other hand, we need data if we're going to get any impression of the impact that we're having. So I understand the complexity around that. Good. Thanks, Anita. Let's move on then to item 3.4. We'll take that from Girish, and then I suggest, although I've not been long joined, I then suggest we take a brief break before we carry on with the rest of the agenda. So, Girish, Learning from Deaths report.
Thank you, Chair. Dr. Girish Kunigiri, Medical Director. This report on learning from deaths is to assure the board that the LPFT is compliant with the national standards and legislative duties related to learning from death. As Anita was already alluding, in the last couple of months, LPFT has streamlined the process for all kinds of deaths and serious investigations, which is in terms of having the right governance and reporting structure, and also how, as an organization, we are constantly learning to avoid such unfortunate incidents as much as possible. Under this learning from deaths, all the deaths which happen in an inpatient setting in the community, but they are in contact with the community mental health teams, and those deaths which happen within the 6 months following contact with LPFT are now being reviewed under the single process. And basically, once they are reviewed, they are put into 3 categories. One is those who will go through the serious investigations, those learning from deaths related to people who have learning disability and autism, and thirdly, those who mark the mortality surveillance review. You can see on the report that there is some variation in the number of deaths as per the data. But again, just to assure the board that these variations are within the normal variance what one would expect or what LPFT has seen in the past. In terms of moving forward, again, I had discussion with the Director of Nursing and also with the Director of Operations in terms of how we use multi-professional learning so that these kind of incidents are properly revisited in terms of the recommendations. And also I had discussions with the Director of Medical Education in terms of using the service users and carers, which was discussed even in the last meeting, in terms of appropriately using them in our educational programs. Lastly, LPFT is a part of the community examiner pilot, which is rolled out nationally. This is a mechanism by which each of the ICS will have few medical examiners who will have an independent scrutiny of all the deaths which are not necessarily picked up by the coroner. And we are hoping that this additional system will help to streamline and provide more support in terms of the investigation process. And just for the board to be aware that nationally there is a new framework which is called as PSIRF, that is Patient Safety Incident Response Framework, which will replace the serious investigation reports. And now we are working to see how learning from deaths will align with this framework so that we continue to have consistency and robust mechanism, both in terms of investigation as well as learning from deaths in the organization. Thank you. Happy to take any questions.
Thank you, Girish, and thank you for a characteristically comprehensive and really helpful report. I don't see any comments or questions from colleagues, so I'm grateful. Thank you very much.
Thank you.
Let's take a brief break there before we come to the people section of the agenda. It's 10:10. I suggest that we reconvene at 20 past. Thank you. Right, welcome back everybody. Let's restart. We'll move on to item 4.1, which is the report from the People Committee. Chris.
Thank you, Kevin. Chris Wright, non-executive director. I'll take the paper as read. I'll just highlight a couple of points, if I may. Amy will pick up on the workforce metrics in the integrated performance report, so I won't focus on those. A couple of things to highlight. Just around our approach to international recruitment, we had a really good conversation about how we have a clear responsibility to our international recruits to ensure that they're supported properly in the communities in which we ask them to work, and how significant that is for us as a trust in welcoming colleagues from overseas here. And then the second point I wanted to highlight is really some of the excellent work that's going on in terms of our use of the apprenticeship levy and the effort that's going into growing our own capability to address the workforce challenges. And I think many organisations out with the NHS have struggled to deploy the levy as effectively as they could, and I think we're probably an exemplar, and we should be very proud of what we're doing. So I'll leave it at that. If there are any questions on the content of the report, please ask.
Thanks, Chris. I've got a question, if I may. I absolutely share your concern that we make sure that overseas recruits are properly, kind of embedded in the community and supported and so on. I wonder whether at a future board meeting there might be scope to hear firsthand from one or more of those international recruits, so that we get, a kind of first-hand personal story from them, so that we can, as a board, reach a judgment about, how well we are fulfilling that obligation to help them settle, as it were.
I think that'd be a really positive opportunity. I think, look, you can't equate these things directly, but there are concerns around the experience of members of our BAME employment group and their experience of bullying and harassment. And we need to ensure that if we're inviting people here from overseas to work in our organisation, we have an absolute responsibility to ensure that they can do that in a safe and welcoming way.
Yeah, completely with you on that, Chris. I think it's a touchstone of how effective we are as an organisation. So yes, I see Amy in chat suggesting that we can take that forward. I think that would be great, Amy, if we can do that. I think it would be important. I think it would be useful for us as a board. Chris, thank you very much. Let's go on then. I think you're next, Amy, aren't you, on equality delivery system?
I am, thank you. So Amy Beaton, Director of People. I'll start with the paper, and then Garish, our Medical Director, also may want to come in with some supplementary comments. So take the paper as read. This is about our equality delivery system, so which I'll call EDS for the rest of the paper. So the EDS is a system that helps NHS organisations improve the services they provide for the local communities, and it also is aimed to provide better working environments that are free from discrimination for those who work in the NHS, and its implementation is mandated. And Chair, just to say, the paper did say for information, it is actually for decision, as is put in the recommendation, so apologies for that. So it is mandated in the NHS standard contract, and it's aligned to NHSE's commitment around an inclusive NHS that's fair and accessible. So it's been in existence for some time, but we're now seeing a third iteration of it, and the most recent iterations due to the new integrated care system architecture, and also taking account the impact of and learning of COVID. So we're on EDS3. And that became available for testing last year. And as the paper highlights, we chose as a system, as an ICS, to pilot this, although organisations could continue to use the last version. However, as the paper highlights, the national launch of the pilot was delayed, and so you will see in the paper this did significantly reduce the time frame. We had to work with it in a truly collaborative and engaged way, and we will change that going forward for when EDS3 is mandated from March 23. The paper highlights the 3 domains we self-assess against. Commissioned or provided services is domain 1, domain 2 is workforce health and wellbeing, and domain 3 is inclusive leadership. And you'll see the paper and the appendix is comprehensive in highlighting the evidence that we've reviewed to determine that self-assessed scoring that we've arrived at, and also the criteria that we need to achieve to improve. And this information was presented as a deep dive for the People Committee last week, so we had the opportunity to go through it thoroughly. And as the paper highlights, the committee agreed with the scoring outcomes, but felt the criteria was limited. And our ambitions as a trust were what we needed to continue to strive for. And we have fed this back to the national team as part of being the pilot. You'll see that our scoring indicated we viewed ourselves as developing in this space. Whilst within domains we were achieving some outcomes, overall we've scored as developing. And as the paper highlights, the main reasoning for this is around things such as the lack of data collected and monitored. So, for example, our access data on health inequalities, splitting our sickness data by protective characteristics, and analysing service user and carer data by quality metrics as well. And there were some other reasons in relation to strengthening and reporting our governance and understanding the data that we do collect and monitor around, as Chris has already mentioned, in terms of our BAME colleagues accessing staff wellbeing service, that's less, and also the remedial action we're taking in terms of the violence and aggression. The paper summarises the actions to be taken under each domain and to improve our rating and achieve our organisational ambitions. I wasn't planning to go through that in detail, Chair, but happy to take questions. I would say being part of the pilot does mean we feel we are better prepared for when EDS3 becomes mandated in March. We have, this is the first time operational services have really been involved in that domain 1, assessing their services, and therefore going forward we would want to learn from those pilot areas, and when we identify which services will be assessed going forward this year, we would buddy them up with those pilot areas. We are definitely feeling more prepared for this process for the purposes of the submission, but we do need to look at better peer review and engaging further with our patients and service users for domain 1. It is a mandated process, as I said, and this does provide a framework, but our commitment on this agenda, it extends beyond this. And as you can see, the paper highlights our commitment as a board in this area, and the fact, although Garish and myself are named against this paper, you'll see that it is across many directors' portfolios, showing our commitment in this area. And then I will ask if our medical director Grish wants to come in, but the recommendation, Chair, really is from the people committee received the deep dive and recommend that board agrees with the scoring detail, but also that we're not constrained by the criteria and we continue with our ambitions as an organisation beyond it.
Thanks, Amy. I've got a couple of questions and comments. Preface that by saying that the detail of this has been gone over by people committee, so it's already had a good coat of looking at, as it were. So I'll go on to comments and questions from colleagues. Sharon.
Thank you, Chair. Thank you, Amy. I think you've covered, our commitment as a people committee and a board to extend beyond the national expectation. I just had a question about aspirations around Domain 1, where we reviewed those 2 services, which I thought was invaluable, the data and information that came out of that work. And is it possible for us as an organisation to look at rolling that out to all of our services to get a baseline of all services?
So I don't know if Garish wants to come in on Domain 1 because he obviously leads on Domain 1. The criteria set, so obviously this year in the pilot, Sharon, we only did 2 services. They mandate from next year to do 3 services, but I can't see why we wouldn't want to use that framework beyond the number that they prescribe, but I'll let Garish come in as well.
Yeah, thank you. Thank you, Chair and Sharon. I think that's a very valid point. As you can see from the report, I think we are, as an organization, we are generally doing well with regard to the EDS on staff and also at the board level, but we really need to gear up from the patient's perspective. So at the moment, I'm working with some of the system leaders in terms of developing an implementation strategy stroke plan for the organization in terms of where we pitch ourselves as an organization, particularly with the access, with the interventions, and also the aftercare following the discharge from the organization, and how this links with the EDI strategy for the ICS. So it may take a couple of months, but that's the direction of travel. Thank you.
Thank you, Girish. I've got Di next.
Sorry, Kevin. Di Bailey, non-exec director. Thanks, Amy. I thought you'd done a stellar job of really reflecting the very detailed conversation that we had in People Committee about the constraining criteria. On reflection, I just wondered, looking again at the actions, whether we needed something in the comms space, because I'm conscious that our data is only really as good as people telling us about the protected characteristics that they have. And I guess it's what we do in that space to help people to feel comfortable and confident to tell us, because we heard very interestingly at the People Committee from at the start of that meeting from a colleague who openly disclosed a disability when she joined the trust and how positive that was for her. So I just think maybe we need an action in that comms space to enable people to understand why we're interested in understanding more about people's protected characteristics and helping people to feel confident about disclosing.
Yeah, absolutely, Di, and we did, as you say, have a conversation around this in People Committee, and whilst the criteria essentially relates to how well we support staff who have disclosed, as an organisation, we are wanting to support a culture of disclosure, where people feel more able to do that. And I think you're absolutely right, that involves sharing stories, as we heard, through a number of communication methods in order to encourage that. So that's on our plan.
Thanks, Di. Ian.
Thanks, Chair. Excuse me. Yeah, I really got into this for the first time having read the report, and I found it quite a challenging read. If I'm honest, it was very, it felt to me process driven, and that's just an observation. It's not criticism. But the thing for me on it, which I just want some clarification on, in terms of patients and health inequalities in particular, I just wonder how we measure the input that we're putting in here. Where will we see where this is making a difference is the thing that came across to me. So I hope that makes sense, because I echo what I said earlier about I found this a difficult one to get my head around.
Thank you. I can come in, Chair, if that's okay.
I'm grateful. Thanks, Girish.
Yeah, thank you. I think that's a great question, Ian. I think from this is what I was alluding earlier. What I want to make myself clear, being the executive lead for EDI, is to ensure that the strategic direction of LPFT with regard to patients' EDI links with that of the ICS strategy. And as I can see from the clinical point of view, my role will be to ensure that we have a robust process in terms of EDI related activities for access to services, and then need to make sure that when the services are delivered by LPFT, they are culturally sensitive and look at the EDI aspects, like for dementia, learning disability, and also for the different ethnic communities, and also to ensure that from the LPFT point of view, when the patients are discharged from our services, we make sure that there is adequate support for them, which are again based on EDI and culturally sensitive measures. So that is what I want to pitch myself for LPFT, but I'm also mindful that I need to work in terms of the prevention strategies, and also in terms of linking with acute care, particularly for physical health and SMI related issues. So there are wider aspects as well. So I want to make myself very clear so that the outcomes are clearer both to LPFT and also to the system, so that there is no duplication or there are no gaps with regard to EDI for our patients. I hope that explains. Thank you.
Really helpful. Thank you.
Thanks, Amy. Did you have a comment directly on this point?
On Ian's point around it's felt quite difficult, and Ian, we would echo that there is a number of EDI frameworks that we have to report against, and what we fed that back through the national team, that sometimes it feels like a layering rather than an integration, and therefore you'll see in the paper there was reference to the national team taking that into consideration and looking at trying to launch one EDI dashboard and reporting mechanism that simplifies it. And I think what we're committed to is, whilst we're mandated to comply with this, we need to do what's right for us as an organisation and ensure that that can feed that, but we don't get wrapped up in delivering for this and missing our ambition as an organisation.
Yeah, really good point. Thank you.
Thanks, Amy. I mean, I confess, like Ian, I didn't find this a particularly straightforward read, but I think part of it is that we're being driven by other people's bureaucratic requirements and not necessarily driven to producing a report that tells us useful things in a way that we find easy to digest. And that's often the dilemma we face, isn't it, with this kind of reporting? Sarah, was there a comment that you wanted to make?
Yeah, thank you, Kevin. I'll be brief, but just for clarity, really, that I think we're on a bit of a journey. I know some people don't like that terminology, but in terms of clarity, Amy is very much the executive lead around EDI for staff. Girish, very much the lead for EDI around our services and our population. There's a massive grey area in the middle because some of our staff are our service users. You know, if we're talking, for example, at Staff Network about people's preference around pronouns, for example, you know, that's as much about how we're making our patients feel valued as much as it is around our staff as well. In terms of the new Mental Health Act that's coming through the processes at the minute, there's a lot in there around culturally sensitive advocacy, which also plays into the space which will very much sit with the Director of Nursing. So as Amy says, it's everybody's portfolio. I just ask the board really to bear with us because we're trying to make sure we're not duplicating. We're also trying to make sure that nothing's falling through the gaps, but you're absolutely right. At the minute, we're very much led by what is coming down in terms of mandated submission, as opposed to, as part of our strategy refresh, what's our ambition for this going forward, and what does that look like in terms of governance and assurance going forward. So thank you.
Thanks, Sarah. That's helpful. We've got a question to answer, and that is, you know, whether or not we approve submission of the report as it's drafted or uploading to the Trust website. Be grateful if colleagues could indicate whether they are content to do that. Excellent. Thank you very much. Thank you, Amy and Girish, for presenting that and for the significant work that's gone into producing it. I appreciate that. Let's move on then to the integrated performance report. Mark, are you going to lead us through this?
Thank you very much. So good morning, everyone. I'm Mark Platts. I'm the Director of Finance and Information. I'm here today to present this month's integrated performance report. The report's based on the December 22 data, so we'll be picking up some highlights from the end of last calendar year. And I'm going to invite colleagues, as usual, to come in to present their key updates. So Chris, I'll hand over to you if that's okay for your operational update. Thank you.
Yep, thank you, Mark. Chris Higgins, Director of Operations. So just highlights really from the operational update section is that just worth flagging at the start of that, there's lots of positive work going on. I know we made reference to that earlier, is there's a few programs of transformation that happen in the organisation and the wider system. One that everybody's familiar with is the community mental health transformation that we're working with system partners on across Lincolnshire, and in particular the community and voluntary service sector, and really pleased to see the launch of the mental health and wellbeing investment fund that's happening at quite a large scale, and that's a process that's currently ongoing to increase capacity within the community and voluntary services sector to support people with mental health problems. So really great advancements in that programme of work, and also linked to that, which has been a key issue for us as a system, is the interoperability of the data so that we can collect and monitor activity and performance across multiple providers with multiple systems. And we've made some really good headways into that, which we'll be able to show and demonstrate return on investment, you know, where's the money going and the activity that's a result of that, and also the outcome measures that service users are managing to achieve. So yeah, really good progress there, and similar work's going off in our children and young people services and our dementia services at a slightly different pace in terms of when that set off, but again we'll be learning from the community mental health programme and using some of that, certainly BCSE development to expand and grow those services. So some really good work to be proud of there. Also, though, we're all aware that there's some challenges in services. They're listed there in the report as the ones that I feel are most pertinent to bring to the board's attention. just a couple to draw out in the conversation is the adult inpatient urgent care staffing. We referenced that in the discussion about the risk register earlier on, and the link to the temporary closure of the male PQ. So that has had, it seems, a positive impact in terms of staffing. That's reflected in a number of bank and agency shifts that are having to be asked for. We can see a quantifiable difference there. But what we're also seeing is a corresponding increase in the number of incidents on our male acute wards, and we're just trying to check that out to really understand what's the impact of that. And we had a discussion at our exec team meeting earlier this week, and the paper that will come back in March setting out the kind of timeline on conditions for reopening the PQ will include a number of quantifiable measures around both quality impact and the workforce requirements. So we'll keep you posted on that. Just other bits to point out is the older adult community mental health teams in Grantham. Previously, we were having real problems in Stamford, Grantham and Lincoln. The Stamford and Grantham situation is stabilised. We've recruited staff into those areas and we're now able to manage things in a better way. Still some challenges around Lincoln, but hopefully we'll see that positive trend in recruitment continue in those services. And similarly, our CAMS team in Boston, overall CAMS waiting times are starting to reduce, and we'll put a full detailed report around that to Sustainability Committee next time. I think in April we're due to bring that back, and just to set that all that progress out. Boston's the area where we're struggling most because of staffing, but overall there's a positive trend there. The final bit on that first section I wanted to pick up is the long-term plan access targets, again referenced in the early part of the meeting by by Sarah Connolly, CEO, around there's two sets of as access targets for a number of services linked to the long-term plan that we're expected to deliver. There was a recognition that they weren't achievable this year, and so we agreed a set of local access targets for the system across the range of services you see there. We're not quite hitting on each of those. I think that links back to our earlier conversation about our ambition and optimism, I suppose, around workforce recruitment that's probably not come to fruition. So whilst we're close, we've not quite hit where we anticipated hitting. What we do know is that going into next year, we'll be much more informed and we'll be able to agree targets that are deliverable. And as you see across the board, it's an upward trajectory. We are seeing a lot more people than we've ever seen before. Services are growing, capacity is increasing, and so we're able to see more people as we're intending to, but just not at the level that we ultimately want to achieve. So and the final point, just pick up, there's one exception report to highlight this month, which is access to consultant only appointments within the community mental health services, and the tag around 18 weeks to be seen. We're not quite there in terms of that access target, should be at 95%, but we're hitting about 80. And there's a number of measures that we're introducing to be able to manage that. Some short-term things around increasing capacity, some extra clinics that have been put on at weekends to be able to see people more quickly, but also some longer-term measures around both looking at the workforce profile for medical staff within community teams, and we think that we've got some gaps and we need to invest some more time and capacity into that. But also we're seeing some really good examples. So Spalding, for example, he's got a really low waiting time and some really effective working going off in that team. So what's happening there and how can we take that learning into other areas? And there's a piece of work looking at that at the moment. So happy to pause there and take any questions.
Thanks, Chris. Question from Sharon.
Thank you. Chris, it's just a question which, you know, you might not actually be able to answer at the moment, but in the paper you set out transformational work with delivery partners, and we're looking particularly at some of the work with our voluntary and community sectors around mental health and children and dementia services. And the paper also sets out some of our more enduring workforce issues in different service areas. And I wondered, or I'm making the assumption that as we develop our community transformational work, we'll need to think differently and review the workforce and skill mix in those teams, and that actually that transformational work could be the solution to those workforce issues. And I wondered whether in future reports we could get a sense of how that's joining up. Did that make sense?
Yes, it did, Sharon. Yeah, absolutely. So there's, I think the backdrop to the community transformation work is that we've had services probably been overwhelmed by demand. So CMHT is under a lot of pressure, high caseloads, crisis teams, and the benchmarking data around crisis teams are that they get double the national average of referrals, double the national average on caseloads. And what we're starting to see, particularly in those crisis services, we've brought on things like the crisis cafes, the other support in the communities, and the urgent assessment centres. We're seeing that referral rate dropping. Now, it's a bit early to get excited that that's a permanent trend, but looks optimistic. But what that is doing is right-sizing the crisis team caseload, and arguably will right-size the CMHT's caseload. And what that does, I think, again, I've talked about with ET colleagues around, we need to capture that information, as you just said, because this is about preventing the need for further investment. It's cost avoidance that we might have had to otherwise build in because the transformation is actually making an impact. So absolutely have to bring that back at a later date and just demonstrate where we're seeing those shifts in activity and what that might mean for us.
Yeah, that would be really great, Chris.
Thanks, Sharon. Chris Wright.
Thank you, Kevin. Chris Wright, non-executive director. Actually, I think I'm just kind of piggybacking on Sharon's question now, because Chris, I suppose one of my concerns is around the access targets and our challenges in hitting them, is that we associate it very clearly with workforce, and obviously there's a relationship between the number of people we've got available and the number of appointments and opportunities we can offer patients. But it's and then you gave the example in Spalding as well around, and I guess my question's around the community transformation piece, what we're doing in the organisation where we're trying to think differently about problem solving, in the knowledge that we've got a workforce challenge, and what the learning opportunities are within the organisation to share best practice, so that we can try and, however challenging it is around people, that we can try and find some solutions to the access issues, because obviously, delays are very concerning for our patients.
Absolutely, and I think there's two bits at play here, in that in order to report on the access targets and the levels of access, we need to be able to report the activity, and this is one of the challenges we've had today, particularly through community transformation and the work with our community and voluntary partners, is that not necessarily have the systems and infrastructure to be able to report that activity in a way that it can be captured and demonstrate the increases in access. But just recently we've had some breakthroughs in that, and we're able to capture that activity. So if somebody's seen in a community voluntary walking group, for example, and that's meeting a need, we're able now in a better way to be able to record that activity, because it is access that's appropriate to that individual. So that's so that work is in a really good stage now. So we're able to report on the extended care network. It isn't all about secondary care, mental health services. I think your other question in there about learning, it's about, absolutely, we're looking at where we've got examples of effective working, but it's understanding what that means. So the example of Spalding's a good example, where there's been a progressive approach to virtual appointments, telephone and video conferencing, where there's been more of an uptake on face-to-face contacts in other areas, and it's understanding what is the best outcome for a service user for service use, and where's the balance within that, because all telephone virtual might not be the right answer, but it might mean ready access. Similarly, all face-to-face might mean great outcomes, but equally it might limit the capacity of the service. So there's a balance somewhere in the middle that needs to be investigated to understand what's the right proportion of virtual versus face-to-face physical appointments, and what's going to get the best outcomes and maximise access. So there is work happening in that space through the community teams and divisional management teams, and as we do our productivity and efficiency work, our demand and capacity work over the next year, we'll really be able to draw those out as to understand what are the right aspects of a care pathway and standardise that in a better way, so that we can measure it and implement it in a more consistent way across the county.
So Chris, the sort of data can be quite a blunt instrument really for performance against KPIs, and how they're measured can be a fairly blunt way of capturing what's going on. So I think, I don't know how we do this, but I think that there's a narrative which underpins this. There's some really interesting stuff going on, which the data probably doesn't necessarily, it doesn't tell us a story. And so I think, just for our own benefit, we need to be telling that story probably a little bit more effectively, in order to explain the context in which we're working as well. I don't know if that makes any sense. It just feels like there's a lot more to this than the pure data is telling us.
I absolutely agree, and I think this is where we need some further conversation. I see comments in the chat around how we develop our IPR to reflect the patient pathway and patient experience. So as an example, we're not reporting it yet, but we're moving to a 4-week wait rather than an 18-week wait for community services, and that's something we'll be pulling into in this coming year, and we'll start to report on where we're at as we start to implement those. And there's 2 measures for adults and children. Children is 1 contact will constitute a clock stop for somebody waiting. Well, that's very easy to achieve. We just see everybody really quickly once and we stop the clock, but that doesn't show that people are waiting then secondary waits for treatment, whereas in community adult services, it's 2 appointments has been the arbitrary measure of you've seen twice, so you must be starting treatment. But that then is a bit counterintuitive when we're asking people to be seen in voluntary community sector groups that don't need multiple appointments with a secondary care agency. So there is a piece of work we need to do over this coming year, really, to unpick all that and be able to demonstrate the care pathway in a meaningful way and how we're measuring that. And I think, again, maybe through Sustainability Committee, we can get into some of that work to say what are the right things to be measuring in what way, as well as obviously the national targets and reporting that we need to do.
And finally, Kevin, if I may, just going back to the Hewitt report, some of this, I think, should be fed back around these national targets into the Hewitt kind of investigation inquiry, because I do think there's there's an opportunity here to tell a different story than the one that those KPIs kind of lend themselves to.
Thanks, Chris. I'm going to move us on, if you don't mind. I'm about to cough. Apologies, I'm plagued by a persistent cough. I just want to pick up on the point that Sarah's made in chat, which is directly relevant to, Chris, your point, and that is that inevitably we're going to have to revisit how we report performance to support our strategic ambitions and the role that we want to have in the system. And I think, amongst other things, that means moving away from a set of metrics that are both organizationally focused and which only feed national targets, and if we realize the strategic ambitions we've got, we'll need a quite different, potentially quite different approach to the way in which we measure performance. Di, you had a question.
I did. Thanks, Kevin. Thanks, Chris. Di Bailey, non-exec director. Chris, I was just struck when you were talking there. You mentioned sort of the national picture, and I just wondered how we fare demand-wise compared to other mental health trusts up and down the country. And I guess it picks up that point about data again. So while in the report we can understand sort of where we've got pressures around staffing, I suspect that we've got different levels of demand in different parts of the county. And again, I think it starts to feed into some of that about how we understand our diverse communities, really, is can we get a sense of where that demand is? So it's not just a case of where have we got the staffing gaps, but have we got the staffing gaps in the areas where there's maybe more demand or less demand, if that makes sense.
Yes, it does. And I think one part of the puzzle is that we obviously know the demand that's coming to our door. So we know the We know that we've got the number of referrals coming through, and we're operationally we adjust our workforce profiles to be able to meet that demand as it's coming to the door. But what we're getting better at is understanding the population needs in localities. So through the community mental health transformation work, again, a bit of a forerunner to the programme is that we've got population need profiling. So looking at deprivation, looking at mental health need in different areas, and then the mental health and wellbeing investment fund is being targeted and weighted for populations where we know that we've got greater demand, and so we can get more sophisticated with that as we move forward. So we are really, it's the early days with that kind of population health profiling, but absolutely we need to understand it's not just the demand that we know about, it's the unmet need that's out there that people aren't seeking help and maybe pop up later on in a really difficult position. So
okay, thanks.
Thanks, Di. Thank you, Chris. Shall we move on then to the quality section in the report? Lucy, I think you're covering this in Anita's absence.
Yes, thank you. So Lucy Kent, Associate Director for Quality Improvement. Just a couple of points to make from the quality section around the daily incident review, closer working between the quality and safety team and the divisions, which is really improving the conversations, the working together and the quality of the data. Second point was around the data on self-injurious behaviour. And you can see from the report that we've got a definite shift in the numbers, but I just wanted to reiterate the note of caution on that we're not convinced that that's due to improvement work. We presume, well, we think that it's due to individual patients and behaviours, etc. So we're monitoring this closely. We are starting improvement work. And we will continue to report on that. The other two areas that we wanted to look at in more detail was violence, aggression and harassment in relation to the two inpatient areas that are probably taking some of the patients that would have gone to PICU, so to pick up on potential impact of the closure of PICU. And you can see from the report that there has been an increase in these instances. So again, we're going to be monitoring that closely and working with Freedom to Speak Up Guardian in terms of supporting staff and looking at that more depth. And also to pick up on the areas that were noted in board last time as being under pressure from sort of operational point of view. We wanted to look in more detail in terms of patient safety incidents, so we've presented that data. Again, there's obviously an increase in one of the inpatient wards relating probably to the VAH incidents, but in the other areas where there has been an increase, we've not seen any clear themes or anything. So again, it's just to provide assurance that we are monitoring that and will continue to do so. Thank you.
Thanks, Lucy. I don't see any questions or comments from colleagues, so thank you. That's self-explanatory. I'm really grateful to you for helping us through that. So we'll move on then to the people section. Amy.
Thank you, Amy Beaton, Director of People. So I just wanted to pull out a few highlights from the People section. Some good news in terms of our turnover has reduced for the third consecutive month. Obviously not statistically significant at the moment, but it is the lowest it has been since October 2021, and our number of leavers in November was the lowest it's been since December 2020. So we are starting to see a downward trend, and our focus and our engagement piece with our staff in terms of our Walking in Our Shoes programme, we are attributing that downward trend to, as we have focused on what staff told us they valued and what areas would tempt them to leave. So, for example, we've used all of our workforce development funding around team effectiveness and training our managers in the Athena Team Journey Coach programme. However, we are continuing to use data more intelligently in this area, and the board has heard me talk before around our additional clinical services staff group being our staff group with the highest turnover, and indeed our turnover rate has decreased across every staff group other than that one, and this staff group contains our support workers, our healthcare support workers. And the paper does reference our continued work on using data for insight. We've analysed our levers by service, length of service with us, and you can see that we are targeting those with less than 12 months service. And just to highlight board, the highest number of leavers in that category of below 12 months service is again our additional clinical services staff group, and our under 30 years, which were a target for us. So we're using data to target the areas where we can have that biggest impact and affect change. The other area to highlight is around our vacancy position. So again, board has heard that we are increasing our actual whole-time equivalent numbers month on month, but we've not seen the same result in reduction in vacancies due to the growth. But in the last 2 months, we have seen that vacancy position reduce. And that has absolutely coincided with the grip and control that we have got in terms of the plan for every vacancy work. So Di's point earlier around the gaps where there's the biggest demand, we are really focusing, whilst we do our triangulation piece around workforce and performance, activity and finance, we have done a lot of work around our workforce metrics and triangulating them and really supporting innovative recruitment and looking at things differently in those areas which are struggling across all of our workforce metrics. And then also obviously the turnover reducing has helped with that vacancy position reducing. The paper also does highlight that we have had a people restructure in the function, and I would just say that additional capacity is really focusing in this area around attraction, recruiting, resourcing and onboarding. So that is going to be a focus for us going forward, and we would be confident that we would see this resulting downward trend. Just also to pick up on Sharon's point, so on page 19, the board did ask us to split core services and new business, which we've done, and the board will see that we are seeing a reduction in our vacancies around new business, but then an increasing trend around the vacancies in our core services. And that is, as we know, is because our internal staff are predominantly filling that new business. So our efforts around recruitment and retention are to slow that upward curve in those core services, whilst we also wait for our interventions around the transformational space for workforce to be realised. So most of this new business is in the community division, and that division has been really innovative in the space of new roles, not only capitalising on the new roles at a national level through Health Education England, but we've as an organisation developed new roles in terms of that psychological intervention facilitator, and so we're moving these roles into that division as well to support. And the paper also highlighted, and Chris, our non-exec director, also talked about international recruitment, and you'll see in the paper that we talked about our recent trip to India in November, and the securing of medics and nurses in that space, but actually the number of nurses we secured was not what we targeted, but that it has opened our eyes to other opportunities with India that we can do around other staff groups to support our supply pipelines. And then just lastly, in terms of highlights, you will see from the executive analysis in the people section, we are doing a lot of work around gaining greater insight through data to really drive that improvement and focus. What our success measures, to pick up on points that have been made, is not just that hard metric monitoring for us to course correct, but also the soft engagement narrative that we're getting through a number of means, like such as our national staff survey, national quarterly staff survey, and walking in your shoes. But a big thank you to our business intelligence team for prioritising some of the development of workforce dashboards in this space for us.
Thanks, Amy. Really important data, and the thing that really bothers me is that although we're obviously making some progress on turnover, the trend lines on vacancies, both for core and new business, are stubbornly going the wrong way. And although that there's a bit of a downward line for the the end of the period covered here, it's probably overly optimistic to suggest that is telling us that we're turning a corner. So I think so two conclusions from that for me. The first is absolutely kind of reinforces the point I made earlier about the risk register, but also I think next time we look at these data, Amy, we need to have something that tells us what we're going to do differently if that trend line still is going in the wrong direction, because I recognize the fact that we're working extraordinarily hard, but if it isn't making a difference, then we have to ask ourselves, do we just hit the horse harder, or do we look at a different set of approaches? So I'm grateful if you take that as an action and then come back with possibly some commentary next time that just focuses on that vacancy trend line if it's still taking us in the wrong direction. Is that okay?
So yeah, I can do that. As I say, the vacancies coming down the last 2 months, but I get your point, it's not statistically significant. And I think the conversation we had in the people committee was for going forward, we're going to take into the people committee in March our people work plan around our strategy, which is really clear on what are the successful measures, what are our trajectories and milestones, and we report when they're not going to that plan, and therefore the conversation on what do we need to course correct that rather than us waiting. So I can absolutely bring some commentary after people committee as well.
Thanks, Amy. I absolutely accept that this needs to go to people committee first, and people committee need to have an engagement with the granular detail. But from a board perspective, this is still a significant risk, and it ought to be the kind of biggest thing, one of the biggest things on our radar. So that engagement with people committee needs to feed into I think some engagement at board as well. I've got two questions, or question and a comment. Question from Ian.
Thanks, Chair. Yeah, it's really just building on this vacancy issue. I think the data analysis is very good. I absolutely echo the way that you're trying to shine the light in the right place, and that seems to be bringing things home. But there was a comment in the report about there's been an outlier compared to other East Midlands authorities. And I just wondered, it really built on, I suppose, Kevin's earlier point. Should we, I can't remember what he said actually. Was it kick the horse or go down a different route? But is there something that East Midlands are doing, either kicking their horse harder or going down a different route that we can learn there?
Yeah, and this really comes down to, so you'll see the report says we're an outlier on vacancy, but our performance is comparable. And I think, Ian, this is really how we are classifying what is a vacancy. And obviously the report talks about growth, and we have had an extraordinary amount of growth, which just basically increases our establishment and then just ups our vacancies. And we saw that last year. So other organisations, some do not put that growth in at the start of the year like we did. So you'll have noticed at the last board we had a massive increase in establishment at the beginning of April, and it has phased every month in. Other organisations don't put the investment and growth in to the establishment until you're at the point of recruiting, or they phase it. So if we take a new service, rather than putting the whole time equivalent in for that new service right at the start of that year, they say no, we're going to phase it over a period of time. And we are certainly having those discussions at the minute in planning on how are we dealing with our vacancies, how are we classifying what is a vacancy. And there's still the cleanse piece, Ian, in terms of you know, we have got some areas shut and paused. So we've got some areas in the organisation that we've temporarily closed. We're not actively trying to recruit to them because we're piloting a different way of working, yet they're still showing as a vacancy. Oh. So we need to, they're the conversations that we're having at the moment in the planning process on actually, is the way we're showing vacancies right for us at the moment, or misleading?
Yeah, I understand. Yeah, thank you.
Thanks, Ian. I understand that too, Amy, but I don't want us to get into a position where we're using a presentation of the data to tell us a story that isn't the story that we need to hear. So just a word of caution. Now, I'm not suggesting that that's what you will do, but I've been in organisations before where the temptation to invest more time in cutting the data in different ways so it tells a better story is disproportionate to, you know, the kind of outcome that it delivers. So I just want us to be conscious of that. Chris Higgins.
Yeah, my comment kind of leads on from that. I think there's just something about, are we reporting comparatively with other organisations and systems, and how the way that they're managing their funded establishment comparable? And I think that's absolutely the point here, is that we've had investment into the organisation to meet the identified need, and then the establishment that's required to deliver that, and that creates a vacancy gap as we recruit up to that, and that's taken us time, and that is a true position of what is needed to deliver the need in those areas that have got those underspends. We're just working as, where there's other organisations, I understand it, won't have that money released, so it comes down in stages, so it appears that they've got a lower vacancy factor, but actually the true vacancy position should be what is fully required in terms of delivering and meeting the need. And I think it's about, as we look through, I think it's a question for us as how we want to monitor and measure this, because ultimately the required establishment is the required establishment. We've been fortunate in Lincolnshire to be able to get that investment early on whilst we recruit up to it, and that's creating a vacancy position and an underspend that we can use in different ways. But it is that bit about if that's the true vacancy position, and I think what's hidden within there, which is again maybe a conversation another time. We know that IAP's a great example, is that if you look at the full investment and workforce that's required to meet the access target, it's way in excess of the workforce and the income that we couldn't receive. And if you put that as a totality as the future workforce requirement, it would show a huge vacancy position, but the money hasn't flowed in that way. So I think there's a piece of work to understand what was ultimately required to meet all those access targets, all that need, because that ultimately is the destination in terms of workforce, but how we report that in the interim is probably something we need to think about.
Thanks, Chris. And I think that was partly my point. In my simplistic mind, if we've been commissioned to deliver a service and we've got the funding to deliver it, but we can't recruit the staff that we think we need to deliver that service, then it's a vacancy. And that's quite quite clear in my mind. And we do have to look both at newly commissioned services and existing services because of the issue of kind of cannibalisation of staff, for want of a better word, where we're staffing new services by taking staff out of old services. So we do need to look at both. And I think, if we've got the money and we're commissioned to deliver a service, we haven't got the staff, then, as I say, it's a vacancy. And I'm less concerned about straight comparison than I am, whether or not, because there's a wider issue here, isn't there, about credibility with commissioners. I'm less concerned, in a sense, about comparisons than I am, can we deliver the services that we are currently being funded to deliver? And vacancy rates are directly determinate of that. Amy, did you want to comment on that before I bring Di in?
Yeah, I think it's how we present it, isn't it? I absolutely agree with what's been said by both yourself and Chris. I think the bit that we need to get better at presenting is this may be the current vacancy position and that may be what's needed for a service. But in 23-24, this is our plan against it and what we feel we are going to recruit to against that, and show that active recruitment. And I also think when we are, and this is why this is important now in our planning processes, when we are putting investment and growth, that establishment, we really think about that, because in some of the areas we've seen an establishment that is traditional roles, which we struggle to recruit, and we're trying to turn this to a skills lens rather than a traditional role lens. So what are the skills needed, so that we're not asking for an establishment, we're not asking for a workforce that we know we're really going to struggle with. And so it's doing that better in the planning process rather than getting a whole load of vacancies in traditional roles that we've struggled with.
Absolutely. It goes back to the conversation we've had before, Amy, about whether or not we're looking at a capability requirement or a workforce requirement. Thank you for that. Di.
Thanks, Kevin. Thanks, Amy. That picks up my question, really, which is, and it's not just a question for you, Amy, I think it's a question for us as a board, is are we really being bold enough in terms of influencing the whole sort of workforce agenda going forward? I'm just conscious that we heard from Cassie this morning, about how important it was when she arrived on the ward for somebody to sit down, have a cup of tea. That orientation was really key. We've heard that before with board stories. We heard so much this morning about how important activities are, and yet we seem to be, sort of berating ourselves all of the time because we can't recruit more qualified nurses, really. And I just think, we need to somehow influence this agenda more so that we redesign a workforce that can deliver some of what we need them to do. And so, yeah. You can sense my frustration with this. It's just a case of, how do we influence this agenda going forward?
And I don't know, Di, whether you're waiting for me to come back on comment on that with your premise that this was for the board. But for me also, it's so the planning process is important for us to have those discussions in, but this also comes back to our aspirations in that prevention space, for me as well, and our links on that, working with other areas that are better equipped to delivering some of this, preventing the demand coming through the door as well. So it's not just about us within, but also externally, the partnerships that we're forming for people to do work at that more preventative level to prevent the demand coming in. So there's two parts to it. In terms of what you've said, I would say that our emphasis is really around skills and what we see, and as a board and as an exec team, we are reviewing that in this planning process in terms of let's look at the skills that are required more than a role, and that's what I could say at the moment.
Thanks, Amy. I'm going to suggest that we try to and that bring discussions to a conclusion, because we need to reconvene privately at midday, and I'm quite keen to give people a bit of a break between this meeting and reconvening at midday. So if you can pull out, Mark, any really significant finance issues, that would be really helpful.
So thanks, Chair. So good morning, everyone. Mark Platts, Director of Finance and Information. One of the key bits that I did want to link in, it links entirely to that full conversation. You know, when the positions and the challenges around vacancies materialise in a financial position, we are reporting a £5 million surplus. That equates to £5 million worth of funding that we haven't converted into patient care as a system. So I think that kind of really brings that whole conversation starkly to home. On the back of that, one of the key things I did want to highlight is our forecast position. Even though we're reporting a significant surplus year to date, we are forecasting to remain on plan. This is likely to change next month. So nationally, the NHS has a reforecasting protocol that has to be implemented by systems who wish to start to report revised forecast outturn positions. So Lincolnshire as a system has made the decision to enact that protocol, and there's a paper that's being discussed at private board later on around that. So when I report the position next time, it's likely to report a much higher financial surplus come the year end. So I just wanted to note that one today, really. The second area of focus, continued bank and agency usage. So that this needs to be an area that moving forward we really do start to manage, because we are currently exceeding what will become our agency cap for next financial year in terms of 3.7% of our pay bill spent on agency. We're currently forecasting a 4.1% spend on agency, so there's a lot of work to do around that. So by filling the vacancies, we'll reduce need in agency, stabilising our workforce. And my final point, Kevin, was just to link back to the patient story at the start of the session with Cassie, Catherine and Jess. We're still on track for completion of the eradication of dormitories schemes to build, so Ellison Castle Ward. So the buildings will be complete and handed over to us in March, and then we have a commissioning period ready to accept patients from June. So happy to take any comments or questions on the finance update. Thanks, Kevin.
Thank you, Mark. That's really helpful, and I think probably self-explanatory. I don't see any comments or questions from colleagues. So, is there anything else you need to say, Mark, to wind up the performance report?
No, thank you very much. That covers presentation of the integrated.
Great. It's been a really useful conversation, particularly around workforce, but touching on other things as well. So, really grateful to colleagues for that. Let's move on then to I think is the last substantive item, which is a report from the Audit Committee. Ian.
Yeah, thank you, Chair. I'll be brief. I'm conscious of your timekeeping. I think the report was pretty much self-explanatory, really, just summarising what we've been doing more recently. If I perhaps just pick up one item that people will have noticed in my summary, just regarding internal audit reports. We've had a couple come in that got partial governance, which is a bit lower than we would ordinarily like. I have to say, though, as I said in the report, I don't think that's necessarily a negative thing. We have, or should I say, Mark has pushed auditors towards areas that we think there'll be some value to us. If you do that, you often get a response that might be slightly uncomfortable in the short term. We have got another extraordinary meeting of the Audit Committee set up to follow through on the findings of internal audit reports, but I'll leave it to that unless anyone's got any particular comments or questions.
Thanks, Ian. Any comments or questions for Ian? I don't see any. Thank you very much. Jenna, forthcoming board programme, which I assume is just a note.
Yeah. Just
Thank
there for noting.
Yeah. If there are no questions or comments on that, I haven't got any other business, and I haven't been notified of any other business by anyone else. So I'll draw things to a conclusion. Look, first of all, apologies for my own personal tech issues at the beginning of the meeting. I thank you again to Sharon for stepping in at the beginning of the meeting in admirable style. I'm really grateful. That's been a really good meeting with some important discussions, particularly around workforce and other elements of performance. So thank you very much, everybody. We reconvene at midday in private session. I suggest that we take a break between now and then so that colleagues can grab themselves a sandwich and a cup of tea or whatever is their fancy. So thank you very much again, and we'll reconvene at 12.
Thank you.
Thank you.
Thank you.
Thanks everyone.